This program is brought to you by the Vegetarian Society of Hawaii, a nonprofit organization dedicated to sharing with the community the many benefits of a vegetarian diet. Free monthly meetings include vegetarian experts found locally and on the mainland, quick and easy cooking demonstrations, and healthful and delicious food samples. Members enjoy an informative quarterly newsletter, social activities, and discounts at many vegetarian-friendly restaurants and health food stores. For an application, call 944-8344. That's 944-8344. Or visit our website at www.vsh.org. vsh.org.
Tonight's lecture will be videotaped, or is being videotaped, for broadcast on the VSH weekly TV series called Vegetarian. On Oahu, this airs on Thursdays at 6 p.m., Olelo Channel 52. We suggest that you tape each show, keep the ones you like or want to share, and then just tape over the others. Because once you've seen it, if you haven't taped it, there is no way to retrieve it again. We don't have copies, and sometimes the shows are repeated every couple of years, but there's no way to predict that. It's now time for our special guest. We're delighted to have with us tonight Dr. John Kristofich. Dr. Kristofich is board certified in cardiology and internal medicine and leads the Heart Check program at Straub Medical Center in Honolulu. His special interests include preventive cardiology and early detection of cardiovascular disease. He received his medical degree from the University of Medicine and Dentistry of New Jersey, Robert Wood Johnson Medical School. He completed his residency at Lehigh Valley Hospital in Allentown, Pennsylvania, and his fellowship at Geisinger Medical Center in Danville, Pennsylvania. Tonight, he will present How to Stay Heart Healthy. Please welcome Dr. Kristofich. There he is.
Okay, thank you very much. As always, it's such a great honor to speak for the Vegetarian Society, and I just feel like every time I do anything for a society, I'm doing it for my family, because they have our best interest at heart, and that's the truth. And I would encourage all of you to, if you are not members of the Vegetarian Society, it's very easy to sign up. It's a small amount. Again, you get such great discounts. I think it's a 5% discount at Down to Earth and Huckleberry, and it more than pays for itself. And you'll find a lot of heart-healthy and life-sustaining products in these places. They're just great places. Only place that I shop these days. So. And what we'll talk about tonight is heart disease, which is going to concern all of us one way or another, either personally or somebody we know, friends or family. I'm sure we all know somebody who's been touched by heart disease, principally coronary artery disease, disease of the arteries of the heart that then affects the heart's muscle. And our objectives tonight will include looking at the scope of the problem. We're going to talk about major and minor risk factors, symptoms, and a little bit how they differ between men and women, which I think needs to be qualified, evaluations, and therapeutic lifestyle interventions. So we'll have quite a litany of things to discuss tonight. Well, when we talk about atherosclerotic vascular disease, we think about several entities, such as coronary artery disease, cardiovascular disease, which will include stroke, for instance, and peripheral vascular disease. So the prevalence is roughly around 25 million individuals in the United States, and the annual rates of some of the manifestations of cardiovascular or atherosclerotic disease includes myocardial infarction, a little over 1 million, 1.2 million. Strokes, about 750,000. Cardiovascular mortality is upwards towards 1 million, almost one death every 30 seconds. So if it takes me half an hour to give this presentation, there'll be about 60 deaths just from a half an hour. Cardiac catheterization is a very technique-intensive specialty. Cardiology is a very technique-oriented and driven procedure specialty with stress testing and cardiac catheterization and stent placements, and then finally bypass surgeries if it comes down to something like that. Percutaneous revascularization or angioplasty is again over about 1 million individuals a year. Surgical revascularization or bypass surgery about a little more than 500,000 individuals per year with big cost. $250 billion are spent annually for cardiovascular disease. And when we think about what's happening, well, when we're born, we have a certain amount of cholesterol in our bloodstream. Cord blood or neonatal blood, it has roughly around 75 milligrams per deciliter of cholesterol. By 2 or 3 weeks of age, it gets up to about 150. It stays there to about puberty, at which point it becomes about 200 or 210 in the average adult. And from then, it continues along its way and slowly steeps upwards towards our later years. And that rise in cholesterol and other risk factors leads to what's called plaque formation. Basically, looking at the screen from the left side to the right side, you can see that over time there is damage to the artery wall, there is deposition of fat and cholesterol inside the artery, and when the cholesterol and fat debris starts to occlude the artery actually does something smart. It starts to enlarge. And as you can see, as we're following the graph from the artery from left to right, it actually becomes bigger. It's a process called remodeling. What's called the remodeling phenomena, and the artery wall starts to enlarge. That's good for 2 reasons, or maybe not so good. One good reason is that it makes us remain asymptomatic for longer and longer periods of time. So if we have more and more grummus building in our arteries, and the artery was not to dilate, we would become symptomatic far sooner. But as it would be, it dilates, it opens up, it actually enlarges. And so it can accommodate more and more plaque buildup and plaque burden before finally symptoms occur. The second thing that can occur is this actual process of remodeling or enlarging of the artery leads to what they call plaque rupture or plaque erosion. So we'll see that in one section, there's sort of a little bit of an area where it looks like a little mushroom cloud there. Well, that's a blood clot that forms on a plaque that has been fractured or fissured or ruptured or eroded. Okay? And if the blood clot that forms in that segment of the artery is severe enough, it will occlude the artery and cause a heart attack. Okay? And that's what we call an acute coronary syndrome. And then finally, as the years progress, it can continue to occur to block the artery, or it may regress depending on what we do to our lifestyles thereafter. Okay, so this process of plaque buildup, plaque destabilization, acute coronary syndrome and heart attack or stroke is the end result of years, actually, of processes that occur on the artery. Fortunately, in many regards, it can be reversed or prevented, and there are a lot of great resources out there for us to understand this better and to try to prevent it in our own hearts and the hearts of those we love. Stroke is another manifestation. Every 45 seconds, someone in the United States suffers a stroke. It's the leading cause of morbidity and third leading cause of mortality for both men and women. Again, we mentioned almost 750,000 new strokes every year. Greater than 160,000 are fatal. There are some other statistics, such as 25% of women compared to about 22% of men under the age of 65 will die within 1 year of having a stroke, and nearly 40,000 women, more women that die each year of stroke than men. So let's talk about the major and minor risk factors, and I'll just list them. And having a heart attack is not a big mystery. It has to do with a constellation of risk factors that tend to accrue in an individual. Going down the list, hypertension is such a strong risk factor for developing cardiovascular disease because it yields higher pressure load and tension on the arteries, and in doing so it enacts a repair mechanism that can lead to increased thickening of the artery. It's very important in terms of stroke. It's probably the number one risk factor for stroke, but it also has a major development in developing blockages in our arteries. So hypertension is very prevalent. It's estimated that about a third of individuals over age 65 have high blood pressure. I'm sure many of you know or may be on blood pressure medication to control the hypertension. Optimal blood pressure is 120/80. Anytime the blood pressure increases by 20 millimeters of mercury, the top number, so going from, let's say, 115 to 135, it doubles the risk. And if it goes from 135 to 155, it quadruples the risk. And likewise, from 155 to 175, it will 8 times increase the risk of stroke. So we concentrate mostly on the top number more so than the bottom number when we're above age 55. In 55 years or younger, we think more about the lower number, the diastolic blood pressure. But again, hypertension is highly prevalent, many times undertreated, and again contributes significantly. Hyperlipidemia, again, is a word that just describes elevated cholesterol, cholesterol in the blood. There are some things to think about. One is the LDL cholesterol, so you should all try to think about what's my LDL cholesterol. Optimal is less than 100 milligrams per deciliter. If a person has manifest atherosclerotic disease, we like to get it below 70, and some data would even suggest getting it to 50 or even 40 to try to lower it that much to try to prevent the progression of plaque formation and emergence of cardiovascular events. Low HDL is the good cholesterol. That's our protective cholesterol. In men, we like to see that above 40. In women, above 50. Again, the higher the cholesterol, the HDL cholesterol, it tends to protect our arteries. It can be increased by such things as exercise or dieting, losing weight, avoiding smoking, etc. And we'll talk more about that in lifestyle management. Elevated triglycerides, again, another risk factor. Fatty food intake is important, and being heavier. Lipoprotein A and homocysteine, not as important as just what the total cholesterol is, the LDL cholesterol, the HDL cholesterol. Tobacco, again, is another important risk factor. Anybody smokes, that's the worst thing possibly can do. It's been shown that in women younger than 45, if they have a cardiovascular event, if they have a heart attack or a sudden death, more than 90% of those individuals will be smokers. So, again, we'll always question about secondhand smoke as well. That is not innocuous. It's not something to take lightly. And it's nice to see that the tobacco laws are changing. Society is trying to become more smoke-free. Diabetes mellitus and obesity, so those two things are very well paired together. We have a fattening of America. I'm sure you've heard others talk about this, is our waistlines are increasing. The obesity rate has doubled since the 1970s. Has to do with more and more inactivity, too much portion, too many fat calories, and too many soft drinks and things like that. Inactivity, again, an important factor. We're just becoming a society that likes to take the car and, doesn't want to walk, doesn't want to bicycle ride and things like that. We have to try to stress to increase our activity level. Chronic stress, depression, anxiety, not really considered by many cardiologists, but very important. I'm going to show you some data from the InterHeart trial. A high fatty and high cholesterol food intake. It always astounds me, and this is one of the reasons that I'm a vegan, is that, I see every day the manifestations of suffering from high fat and high cholesterol diets. I mean, we are having a heart attack. It has a lot to do with how much cholesterol is in the bloodstream. Why would anybody want to take in more fat and cholesterol? It's beyond me. So we have a process that's killing us. Why would we want to take in more of that substance which is actually harming us? Inflammatory markers, you may talk to your doctor about something called a high sensitivity CRP. It's a good marker that kind of hones in on who is building plaque in their body, and there are certain levels of this marker that will indicate a low risk or a moderate or a high risk. So something to think about if you see your physician to get that. It's a simple blood test. If we have other evidence of atherosclerotic disease in our body, if we've had previous strokes, or we have poor blood supply to our legs, or we suffer from blood clots, that also puts us at a higher risk. If we have chronic kidney problems from either diabetes or from high blood pressure, that also is associated with the risk of having a cardiovascular event. And other types of inflammatory diseases, such as rheumatoid arthritis or lupus, can lead to the spectrum of cardiovascular disease through its inflammation and plaque formation. We can't do much about our age. As we get older, we're more at risk, clearly. Women tend to be protected, especially up until the point of menopause. But after age 65, men and women tend to have equal risk for cardiovascular events. Women in their younger years, with natural estrogen and hormones in their body, they tend to be protected. Alcohol use, again, there has been some data. It's pretty consistent that very moderate alcohol can lead to less risk for cardiovascular events, probably through its ability to increase the good cholesterol in the bloodstream. So again, as I mentioned initially, having a heart attack is not a big mystery. If you look at those individuals who've had heart attacks, this is prevalence of risk factors among patients with coronary heart disease, big data, 34,000 women and 87,000 men. You can see that the risk factors of hypertension, high cholesterol, diabetes, or smoking, or the absence of those risk factors, you can see that over 80% of patients who have coronary heart disease have one or more risk factors. So again, it's not a mystery. Again, just to reiterate the point that diabetes is such a strong risk factor for having a heart attack, and obesity as well, that those two things go hand in hand. And here's some data from 1991-2001 showing that we are becoming more of a fat nation. You can see that in some areas, especially the southeastern part of the country. Mississippi, I think, has a dubious honor of being the fattest state. We can see that the prevalence of diabetes here is very high. It so happens that these are the same areas that have the highest obesity rates. And what's really shocking is our children, to look at our kids becoming obese and knowing that they're going to become diabetic. It's said that if a person becomes diabetic before age 20, they lose nearly 25 years of their life. So when I see a young person with diabetes, I think that they're never going to make it to retirement. They're probably going to succumb from some sequela of cardiovascular disease. Again, this is a very important study. It kind of nailed home the impact of multiple risk factors. It was called the InterHeart trial. It came out in 2003, actually 9/11 2003. What this showed is that this was a study looking at 12,000 first-time heart attacks in 52 countries, and it case-controlled them to other patients that were located in the hospital, and it sought what was the prevalence of certain high-risk factors in these patients who had their first-time heart attack. And so the risk of heart attack is seen the left, starting from 1 up to 512 times the incidence, and the risk factors on the bottom. And what we see is that if a patient was a smoker, they had about a 3-fold higher risk. And if they had diabetes, again, 2 to 3-fold, high blood pressure, again, similarly, maybe 2.5. And this ApoB, ApoA1 ratio is the level of bad cholesterol to good cholesterol. But if they had 1, 2, and 3, if they were smokers, diabetic, and hypertensive, what we saw was a very high risk. And if they had all 4 risk factors, much even higher, 34 to 40 times the rate. If they had all 4 factors plus they were obese, much higher. All 4 factors plus obesity plus psychosocial factors such as hostility or anger or cynicism, much higher and still. And then finally, if they had every single one of these risk factors that they looked at, they were off the charts, basically. So you got to tend to look at yourself and say, well, what do I have? Do I have high blood pressure? Am I a smoker? Am I under a lot of stress? Do I have diabetes or any evidence for diabetes? What's my waist size? Am I greater than 35 or 32 in a woman and greater than 38 or 40 in a man, inches? These types of things. Do I have a lot of these accruing risk factors? I'm at high risk, whether or not I have symptoms or not. So heart attacks are not a mystery why they happen. We need to know our risk factors, and we need to know the severity levels. If you have an LDL or LDL cholesterol, total cholesterol 400, that's an incredible risk. A lot of people are unaware what their cholesterol may be. We need to try to use aggressive lifestyle management to favorably influence these risk factors, and I'll talk more about that later on in our presentation. And medical surgical means, if necessary, to bring them under control. And sometimes we need to be a little bit more aggressive, especially a younger person who, let's say, is so morbidly overweight and cannot by any means get their weight down. They tried everything, and you have to think about, well, should we, entertain bariatric surgery, or if they tried everything to get their cholesterol down, should we entertain the use of drug therapy, etc., to try to favorably modify these risk factors. Now, the symptoms are somewhat different between men and women. I want to just kind of highlight this. If we call women about what symptoms they have of heart attacks, looking over the years from 1997 to 2003, we see that about 2/3 of women think that symptoms of a heart attack includes chest pain, or pain in the neck or shoulder or arm, about 50%. Chest tightness, pressure sensation, only about 1/5. Many of my patients that come in with heart attacks, they don't have pain. They may have just a lot of heaviness or pressure or squeezing. Shortness of breath, about 30%. They said nausea, about 15 to 10%, and fatigue, about 5 to 10%. But what are the woman's early warning symptoms of acute heart attacks? Well, these are 500 women in New York surveyed 4 to 6 months after discharge, and mostly were white, high school educated about half, and older, about 66 years. Many responded, and when they asked the women, what were your symptoms before a heart attack, many of them, about 3/4, said fatigue. So I take it very seriously when a female patient comes in and says, doc, I'm just very tired. I don't understand. I just don't have any get up and go. I feel kind of exhausted most of the time, and it's very unusual for me to be this way. I often think that something may be going on with their heart, that they may be in the midst of having a heart attack in the near future. Sleep disturbance, many report having problems sleeping or falling asleep. Some will report shortness of breath, and very few will report chest discomfort, maybe about a third, as a prodromal symptom. Now, if you ask those women, what was your symptom when you came into the emergency room? Okay, this is what you responded. About 40% were fatigue. Weakness was about 50%. And shortness of breath and chest discomfort were almost about 2/3. So again, a little bit different than what women respond if they never had an event. Some would say, well, chest tightness, chest pain, 3/4 said chest pain. But actually, the acute symptoms are a little bit different. Men, on the other hand, tend to have chest pressure, tightness in the chest. Okay, they tend not to come in with the prodromal symptoms of, I've been tired for the last few weeks and such forth. Most men come in right off the bat. They've had crushing pain, sweating. They woke up with it, or they had it early in the morning. Versus women coming in just feeling exhausted or out of breath. And what I like to bring home is that, first of all, in terms of symptoms, we all are at risk, some risk, since we all have plaques. None of us in this room, unless maybe you've been a vegan for life and your cholesterol is 100, we all probably have some degree of plaque. And, we can live with a little bit of plaque in our arteries. We can't live with that plaque rupturing and causing an acute heart attack. So we all are at some risk, and we need to remember that. Don't underestimate, number 2, don't underestimate chest complaints or misinterpret their significance, which can signify plaque instability. Some patients will say that, it's just a bad chest cold, or they have indigestion, or some will say, I have a bad toothache, I woke up with this morning, and their jaw hurts, or they have a bad earache, and their face hurts, and it's going down the side into the shoulder, they twist themselves, or the cold air hit them when they were in the cabin last weekend or something. So try not to underestimate chest complaints, especially if we have some risk factors, okay? Rarely individuals will have no symptoms at all, and unfortunately need imaging studies to detect serious pathology, and we'll talk a little bit about that. For those of us with stable angina, that is the symptom of coronary insufficiency or lack of blood supply to the heart. For those of us that have that, be aware of the changes in your angina that warrants immediate evaluation. I always tell my patients, those patients who have some chest discomfort when they're active and they're walking and they get some tightness and it goes away when they rest, I tell them try to be aware that, if it starts to get more severe or more frequent or harder to get rid of once you have it, such as stopping or taking nitroglycerin, or it's much stronger when it comes on. Those are signs that there may be something acutely going on where the plaque is getting worse, and it can often underlie a major heart attack that can occur in the next several days. If a patient also wakes up in the middle of the night with tightness or pressure or an elephant feeling on the chest, they really should come into the hospital. Okay. The other thing to remember is that time is muscle. If we can get to the artery quickly and open the artery within 2 hours, we can often save 90% of the heart muscle. But if we get to open the artery after 6 hours, many cases there's permanent damage. Not always, but many cases. An important thing here is that many of the differences in men and women and how they supposedly respond to heart attacks basically has to do with timing. A lot of times women will underestimate their symptoms and they'll come in late, or even the doctors in the emergency room won't understand that they're having a heart event because they're complaining of tiredness, or maybe they just feel run down. And this was a study looking at, in New York again, over 1,000 patients. Men tend to be younger with their heart attacks and undergoing angioplasty. Okay, this is first-time heart attack. 59 years versus 65 years in women. Women tend to have more high blood pressure, more diabetes, and more manifest evidence of atherosclerotic disease in their other parts of their arteries in their body than the men did. And what we saw here in this study is that the treatment of men in red was much quicker. Many more men got treated less than 6 hours than the women, 74% versus 63%. And consequently, shock rate, in-hospital shock rate in men was much less, 17% versus women, 25%. And the in-hospital mortality or death rate was far different, about threefold, about 2.3% in men and 7.9% in women. And so, again, I think what it's saying here is that there may be some differences between men and women in how they respond to medical therapy or angioplasty, but the way I read it, I take it to be more of a time issue. And so once you, and further studies would show, once you eliminate time differences in treatment, men and women respond pretty much equally. Again, just to reiterate some points, clinical manifestations of coronary disease lag in women by about 10 to 20 years after MI and sudden cardiac death. More than 9,000 women younger than 45 sustain a heart attack each year. So again, these are mostly smokers. Women younger than 65 years more likely to die from a heart attack than comparably aged men, probably because non-recognition. And among survivors, 25% of men versus 38% of women die within a year after initial heart attack, and within 6 years after a heart attack, about 18% of men, but 35% of women will have a recurrent heart attack. And I kind of point these differences out because a lot of women think that, you know, my major risk in life is breast cancer or uterine cancer, and actually heart disease causes more death for women than the next 7 causes of death combined in women. So, you know, it's very important to spread the word in February's Heart Awareness Month, and especially for women, to realize that they do bear the brunt of the prevalence of cardiovascular disease, much more than men today. Let's talk about evaluations. So what do we want to do in our evaluations? We want to try to detect blockages and their severity. There's different ways to do that. We want to prognosticate about the likelihood of future events. Like I mentioned before, we may have plaque in our arteries. Well, that's okay if it never doesn't do anything. If it just sits there and behaves itself, okay? We can live with that. We like it not to be there, of course, and there's ways to remove it. We want this testing to be accurate. We want it to be safe and not expose us to undue risks. We want to be able to treat the blockage if it's found, and we like it to be cost effective. And there are various modalities, and they all have good points and bad points, and I'll try to highlight that. There are various stress testing modalities. For example, the most common is a treadmill, where they put the electrodes on and walk on the treadmill. For those who can't walk on the treadmill, there are different ways to do stress testing, okay, with chemicals or such forth. And we can often combine treadmill testing with other imaging studies, such as echocardiography, to try to assess how well the heart is pumping, or nuclear imaging to look at how good the blood supply is to the heart. And it tends to be a very powerful technique to detect severe blockages, but also to prognosticate who's going to have an event in the next year or two. So it's a very common way for a patient to see if there's any blockages and also to see how they do on the treadmill. And that also gives us some idea how far they go, how's their blood pressure response, how's their heart rate response. These things give us a lot of data about how that person is going to do in the next 12 to 24 months. Calcium scoring is all the buzz. There are a lot of places that do calcium score of the coronary arteries. One of our former physicians, Dr. White, does that at Holistica. We do that at Straub. Basically what it does is you run yourself through a scanner and it comes out with a number. It's called the Agatston score. The same fellow who is on the press today about the South Beach diet, and he developed this scoring system. And basically it's individualized for sex and for age. And what calcium in the arteries tells us is that there is plaque. There is definitely atherosclerosis. So if a 65-year-old man goes in through the scanner and comes out with a 0 plaque score, very unlikely anything is going to happen in the next several years to that individual. Whereas if that individual goes through and comes out with an 850, they have a high burden of coronary disease, of plaque burden, and it can correlate with the possibility of upcoming events. So calcium scoring exposes the individual to some radiation, not as much as, say, the next technique, which is the 64-slice scanner. This is a way to detect and characterize the blockages. So this actually give a picture of the arteries. It can look at the calcium in the artery as well. It can look at the plaque and sometimes characterize it. Is it soft plaque? Is it hard plaque? Soft plaque more likely to rupture and cause a heart attack than hard plaque. And so that's an emerging modality. It exposes, unfortunately, one of the drawbacks of this technology is it exposes individuals to quite a bit of radiation. You know, if you look at the measures of radiation, if I can put it in layman's term, if you go in and have a chest x-ray, it's about 3 or 4 days worth of having radiation. If you go in and have a 64-slice CT scan, it's roughly about 3 years. So, you know, and the odds of developing a cancer from that type of radiation is about 1 in 2 to 1 in 3,000 chance. So there are some individuals out there that are recommending, hey, get your 64-slice scan every year. I don't see a good purpose for that because it just is going to expose the individual to a lot more radiation risk. But it is an emerging therapy, and it will have its place in detection and prognostication. Intravascular ultrasound is a technique that is done in the catheterization laboratory. It's an ultrasound catheter. It goes in through the skin just like a regular coronary artery catheter, and it can look at plaque much more detailed than the 64-slice scanner. It tends to be more of a research tool, and principally it's used today in studies that look at drug therapy for individuals and looking at plaque regression. So there's a lot of studies that are coming out now in the literature looking at, well, if we lower the cholesterol to this level, what happens to the plaque? So they look at the plaque and they put a person on, or a group of people on intervention or medical therapy, and then take them a year later or 18 months later, put them through the scanner, put them through the ultrasound again, and then look at what has happened to the plaque. Has the plaque regressed? And it has shown that we can try to regress these plaques with aggressive therapy. Coronary angiogram is the standard where we inject X-ray dye into the arteries. It doesn't look at the wall of the artery, but looks at the blood flow of the artery. And it also allows us to do angioplasty or stenting, procedures that actually will open up a blockage. If a person's been symptomatic and they have a tight blockage, it can open that up. Positron emission tomography or PET scanning, again, looks at absolute blood flow to the heart. Again, not widely available. Angioscopy actually looks at the artery directly through light. Again, invasive procedure. And then cardiac MR, again, it's growing in its use as well. Principally, most of the studies that we use are the first 4 to 5 studies. So what do we need to do? Well, first of all, if we are smokers, we need to stop smoking. And it's nice to see that the smoking rates from the 1950s, where 50 or 55% individuals smoke, has actually dropped to about 20-25%. There are still hotbeds in the country and hotbeds in the world. Different drugs have come out that really help people try to stop smoking, and you can talk to your physician about that. Increased daily activity is always important. You know, get out there, routinely walk. Try to walk every day, half an hour, 45 minutes, whatever it is that motivates you, dancing, whatever it may be. Move. 10,000 steps per day is probably the target to try to increase our activity. Take the stairs instead of elevators, park farther away, walk if you can instead of driving or taking the bus, and get an animal and go for walks and such forth. Food intake, again, this is a sensitive topic with me and my patients because they all know that I'm vegan and they don't want to give up their lau and they don't want to give up their malasadas and everything else. And I even have some physicians banding against me right now. No, I'm only kidding. But, you know, I try to take the time to talk to my patients about the importance of ascribing to a vegetarian or a vegan diet if you can, because if you look at the cholesterol level of a vegan, it's about 130. If you look at the cholesterol level of a vegetarian, it's about 160. And if you look at the cholesterol level of a meat eater, it's about 210. So again, it's very hard. I don't have too many. I can't remember one vegan that walked through my emergency room doors with crushing chest pain. I just don't see it, you know. It's very rare to have a vegetarian come down with a lot of illnesses, especially pertaining to the heart, because their cholesterol and fat intake is so low. So again, I like to say that is the best diet for heart disease prevention and for reversing. And that was, Dean Ornish looked at that in his seminal work back in the early 1990s with reversing heart disease, looking at a very low-fat, low-saturated diet, nearly vegan diet, and showing that you can reverse beyond medical therapy coronary disease. You can improve the lives of patients, improve angina, and improve mortality. Portion control is always important. Try to stress that in terms for weight control. I ascribe to organics over conventional farming, of course. A big topic today is trans-saturated or partially hydrogenated oils used in cooking and baking products. Again, these are very evil type oils. They really destroy good cholesterol and are very much implicated in causing heart disease. And of course, by the plague, avoid fast food places. Monitoring your progress is always important, so you'd like to know what your sugar is, your blood pressure is. You want to try to monitor your weight and cholesterol values. Be involved. I always try to get my patients as much as possible, encourage them to get a BP monitor and basically put their values on a report card and follow them from time to time as they go through their years with me. Stress, anxiety, depression, again, important, whether it's yoga, meditation, massage, long walks, self-help books, seminars, counseling, whatever it may be. Stress is so rampant and has a lot to do with coronary disease. We don't really discuss it as a physician body. It's kind of poo-pooed in a lot of cardiovascular research. The brunt of the joke is, well, there's another study that doesn't show anything about treating depression on heart disease. But they're not well done studies, and it clearly is important because stress has its definite links to the heart. Part of the Reversing Heart Disease program that Dean Ornish pioneered back in the early 1990s did a lot of this, did meditation and yoga, and was instrumental and along with a low-fat, vegan-type diet to reverse heart disease. We want to try to avoid unproven therapies, aromatherapy, chelation therapy, ultra-mega super vitamins, other type supplements. A lot of patients come in with a whole bag full of compounds and things like that. I said, what's just wrong with having a good diet, Get some good green leafy vegetables and juices and smoothies and, whole seeds and grains and nuts. And I try to ascribe to that, and I try to practice what I preach. So I'm not a big fan of a lot of different types of supplements in general. In terms of dieting, there are a lot of things in the foods we take in that we don't know helps us. A lot of antioxidants, and you'll hear about that next month, apparently. There are a lot of things in foodstuffs that we can't even quantitate. First of all, they have a lot of fiber, which is always good, a lot of complex carbohydrates, but there are a lot of compounds in these, especially organic type farm products, that we can't even quantitate now but have really life-sustaining effects on us. So it's better not to get it in the bottle. It's better to get it just straight out of Mother Earth. So in conclusion, know yourself and be honest with yourself. If you look at yourself and say, I have a smattering of these risk factors, well, seek ways to treat them and be honest with your progress. And I also like to say to my patients, as I said this morning in a presentation at the Hawaii Prince this morning about being a vegetarian and being a vegan, is that it's important to look at what we're eating because that has profound impact on our health and on the health of others and our environment. So know yourself, be honest with yourself, and work towards improving those risk factors that cause heart disease. Know your risk factors, know their severity, get proper evaluation and treatment of these risk factors. If you're a 60-year-old person and you go see the doctor and your pressure is fine, your sugars are fine, your cholesterol is 140, you're ascribing to a vegetarian or vegan diet, and you like to walk an hour a day, you have no symptoms, well, you don't need any more testing. You don't need a calcium score and all this sort of stuff. It's not necessary. But on the other hand, if you have, risks, then you should have some of these things more detailed for you. And especially with diabetes, because a lot of times symptoms can be silent, and your doctor may want to suggest, well, get an EKG or get a treadmill test or something like that. See if there's something that we need to be more concerned about. We want to maximize therapeutic lifestyle interventions. This is very hard to do for physicians to talk with patients. You know, we're so pressed for time, and we got to see so many patients that, you know, it's much easier for physicians to sort of just give a pill and say, well, this is for your sugar, and tell them, instead of telling them, well, cut down on the simple sugars and eat more complex starches and get out there and walk Fido every morning for half an hour, and that'll improve your sugar more than this pill will, you know. Or, well, you know, your cholesterol is high, but, you know, don't worry about what you're eating, just take this pill and that will lower your cholesterol. And the same thing for blood pressure, and the same thing for this, that, and the other thing. It's a real disservice, you know, and it's one of the beefs that I have with the medical institution. But, you know, it's part of it is just inertia too on the patient's part, you know, and our lifestyles and what we're so used to, you know. And it's hard for people to break the habit. I remember talking to them today about being a vegan and all the wonderful things that will occur when a person is vegan. Their health will improve dramatically. The compassion involved in being a vegan and how the animals won't suffer. And I'm looking out in the audience, and it's like, I don't know, it seemed like nobody's registering. And it was like, you're crazy, you know. I'm not going to give up my tailgate party, and I'm not going to drop my lao, and I'm not going to, you know, it's not going to happen, doc, you know. But that's why I'm a very busy cardiologist today, you know, and a very rich one too. You know, I make a lot of money, you know, doing this, because, you know, it's sad that we have the power in our own hands to really prevent disease, and we just don't get it. You know, it's like Dr. Phil, you know, with relationships. You just don't get it. You know, a lot of patients just don't get what it takes to be healthy. And it's not a mystery. And it takes courage. It really does, to take courage to say, well, you know, I'm going to be vegetarian. I'm going to try to really, you know, get away from animal products and exercise and not smoke and maybe ricochet these ideas off of my loved ones and my friends. If we were able to do that, we would stop a lot of dangerous things happening in society, a lot of global warming and a lot of obesity and a lot of animal suffering. And so I would say, just try whatever you can do. I mean, if you can't be total vegan, well then be vegan for a day, you know, or be vegetarian for a week, or do something to try to, you know, make that way towards reducing the suffering that occurs when we eat a lot of meat products. And in doing so, you'll reduce your own suffering, because you'll be more healthy of it, you know. I must be honest, I wasn't always vegan. I was, you know, a regular eater until 4 or 5 years ago, and my daughter, you know, my wife called me one day and she says, we're going vegetarian. I said, well, that's fine, great, you know. Well, what made you do that? And she said, well, you know, Gabrielle looked at a video, Meet Your Meat, you know, that she saw the way the animals were being affected. And, you know, all you got to do is show kids the way animals are being mistreated, you know, and they say, hey, this is no way. I don't like animals being mistreated. Kids are very impressionable with this, you know. And, you know, it was quite touching, because my 9-year-old daughter basically, you know, saved our family, you know, little kid, saved our family. So, you know, it's great to see that we become vegetarian. My animals, I have 5 dogs and a cat that are vegetarian. I mean, and these are carnivores, for God's sake, you know. I mean, you know, but we can't give them, you know, we can't give them meat. We just don't want to see any suffering of animals. So we give them a vegetarian diet, and they're doing great. You know, they're doing beautifully. So again, I just implore you, as a cardiologist doing this and seeing a lot of suffering, to really make the effort to take some of these ideas to heart. They're not, you know, high-tech ideas, you know. I mean, a lot of times in medicine we think about, oh, we need a new gadget or a laser or some new procedure, or there's a new CAT scan here and this is coming up, and we just don't see the simplicity and the beauty of doing simple things, you know, of having a good diet, exercising, not smoking, having good interpersonal relationships, These are the things that will cure heart disease, not in a pill, not by a catheter, not by a stent, not by a bypass. That does not cure the disease. We can cure the disease, but it's going to take courage from all of us. We just need to remember that every day that God has given us here. And I'll take any questions, and I appreciate it. I'm sorry I'm so long-winded. It's an important subject to me, and it's real and near and dear to my heart. Okay, let's take some questions. Yeah, right here. One question for you. Okay, the question was, why didn't I mention bicycling in terms of exercise? And, you know, you're right. I mean, I think I should have mentioned that. I could have mentioned swimming or surfing. What I would say is that anything that gets you moving is going to be great. You want to try to incorporate any activity that you'll do day to day. You know, walking, we all can walk, but if you can bike every day, great. You know, definitely wear a helmet and watch out, because, you know, these fatalities that are occurring out there are quite alarming. I'm a runner. I do running. I've been running 25 years. I've done Kung Fu for 10 years. So I'm a runner by trade, but my knees are starting, and so I tend to bike now a little bit more with my kids, and swim a little bit more and do ellipticals and things. So yeah, anything you can do to try to increase your activity. And it comes to about maybe half an hour a day. You don't have to be 3 hours in the gym. That's not necessary. Anything that gets your heart moving, where you're breathing such that you're a little bit out of breath, but you're still able to carry on a conversation. If you can do that about half an hour a day, you're doing great. You know, you're doing great. Yeah, next question. Okay, so the question is basically looking at our cholesterol, flaxseed oil, and what's the good cholesterol, what's the good fats, and such forth. I think I can answer that. It's unusual, to be vegan and have a cholesterol. It's not unheard of. I do have patients that are like that. My oldest patient she's 97 years old. She's never tasted meat her entire life, and her cholesterol is 260, her HDL is in the 30s, and her LDL is 140, and she's lived 97 years. So I said, you'll probably be fine, okay? That's number one. So I wouldn't worry about your numbers. As far as oils, I would tend to agree with you. I think what we try to gravitate more towards are those oils that give us the building products of omega-3 fatty acids, which are so-called the fish oils. But, as Dr. Harris mentioned in his book, the scientific basis of vegetarianism, the fish get it from the plants. They get it from, the algae, and the algae, the plankton grab the algae and such forth. So what I would ascribe you to would be to use oils such as flaxseed oil. Don't cook with it. Same thing with hemp oil. When I make my sauces, I'll tend to let it cool, and then I add the hemp oil or the flaxseed oil. Pumpkin seed oil is good. Those are the ones I pretty much ascribe to. They're very good. They're the shorter chains, but I think they are just as protective. Walnuts also have very good oils. Avocado also will be a good oil. So they don't tend to raise the cholesterol per se. Or if they do, it's going to be a minimal effect per se. I would not worry about it. My cholesterol, I'm vegan. My cholesterol is 180, and my LDL is 104, and my HDL is 46. So I'm not worried. I could care less. I know I'm eating a vegan diet. I'm doing the right thing. I'd be shocked to drop over from an MI with being a vegan. I just don't see it. As far as the other oils, animal oils are the worst. Saturated fats are the worst oils. They become cholesterol. Animal proteins are the worst proteins. Animal flesh, just sitting, rotting in the guts. And the colon definitely leads to colon cancers and prostate cancers and things like that. There's a lot of literature. Every newsletter the VSH sends out is packed with this stuff. The question was, accepting the cholesterol levels of a vegan, and what about the higher blood pressure levels as we get older? When I was in medical school, the blood pressure considered to be normal was your 100 plus your age. I'm not sure, did they ever teach you that, Bill? They taught me in medical school, so if you were 60 years old, you could have 160 blood pressure, and they also taught me that the average cholesterol was 200 plus your age. So if you were 60, 260 was okay. The only problem with high blood pressure, there's so many people with high blood pressure that the data on high blood pressure is unequivocal. There really is no J-shaped. Well, there is a J-shaped curve, because if you have if you have blood pressure of 0, nobody's alive. But if you look at blood pressure, the higher our blood pressure goes, definitely there is more risk of stroke. That's the unfortunate thing. And as we get older, it has more of an impact. So if I'm 25 and I have a systolic blood pressure 170, my stroke risk is far less than if I'm 75 and my blood pressure systolic is 170. So the ultimate blood pressure, the best blood pressure, where we see the stroke rate really be minimized as we get older, is about 115. The thing about blood pressure, it's hard to measure if you just measure in your doctor's office. A person may have white coat hypertension. So many cases I tell individuals, get your own blood pressure monitor and just keep an eye on it at home and just take frequent recordings. If you find it's in the 115s to 120s, you're good. If it starts going into the 130s, you should be very careful. If it starts going above 140, the risk is higher, and whether or not you want to do things to try to lower it, it'll be your prerogative to do that. I had an unfortunate lady about a couple of weeks ago who I've been pleading with to get her blood pressure under better control. She never wanted to change her medicine, and then I find out that she ended up unresponsive in another hospital, and she had a brain hemorrhage. So, the sad point about blood pressure is that it is treatable, and sometimes no matter what we do, even having the best of diets, avoiding sodium, we still need something to treat it, unfortunately. And it becomes a question of benefit and risk whether or not we take those steps to treat it. So, believe me, I recognize that the most invasive thing you can do to a patient is putting your pen to the prescription pad and giving them something to take every day. That's a really hard thing for me to do. I do it with such reservation, but when I'm faced with a patient that has such a alarming risk factor, I have this heart-to-heart talk with them, and I say, listen, I just don't like this, and I don't like giving you pills, but I can't, it's hard for me to accept the pressure 165, Mrs. Schwartz or whatever. And slowly over the years, the rust settles in the pipe and it starts to choke off the artery. It tends to be an active process, almost the way, if we get a pneumonia or an infection, we get bacteria in our lungs, and there's inflammation and our lungs fill up with fluid, and we get a fever and our white cell count goes up, and we get deathly ill and we start shaking like I had about a week ago when I got the flu. So this is an inflammatory response. Our body senses injury and it sets into the effect something called inflammation. There are a lot of inflammatory markers. So there are things we can assay in the blood that tell us our body is under attack. Our bloodstream is under attack. One of them is hsCRP, but there are others. Serum amyloid A protein, interleukin-6, fibrinogen, white cell count, etc. hsCRP is high sensitivity CRP. It comes from the liver. It's assayable in the blood. It's a very stable marker. It tends to be stable from check to check in the individual. And that number, when it's elevated in low levels, signifies a low-level inflammation. So that individual that, let's say, has a CRP level, let's say 3.7 milligrams per liter, is at a higher risk for having a cardiovascular event than if their level was 0.37 milligrams per liter, or less than 1, let's say. No matter what their cholesterol is, no matter what their blood pressure is, it's actually an independent marker of having a heart attack or having a stroke in the near term. Similarly to, let's say, the calcium score, or to what's the thickness of the intima in the carotid artery, or what the ankle brachial index, what's the difference between the blood pressure in the upper arm and the blood pressure in the lower leg. These are markers that we can use to sort of prognosticate. We won't want to predict who's going to have the big one, So it's another way to look at what's my risk. So if I have a patient comes in and they have a high cholesterol and they get their cholesterol down, I check their CRP and it's very low, they are at extremely low risk of having an event. Or if they've had an event and their cholesterol is high and their CRP levels were high, and now we go through the dictum of trying to get them to stop smoking and exercise and get a better diet, lower their cholesterol, and they do that, and they have great cholesterol lowering, and their levels are very low, and their hsCRP drops like a hot potato. They're very well treated. I feel very comfortable that they're going to do very well in the near future. Unlikely they're going to come back with another heart attack by the end of the year. So it's another marker that you can measure to sort of look and gauge where you are in your risk for having a cardiovascular event. Yeah. What I want to try to emphasize there is that, if an individual is going to do, let's say, an aromatherapy and think that they're going to lower their chance for heart disease and continue to, let's say, smoke or have high blood pressure and untreated or have a horrible diet, probably not going to work. We don't have a lot of data on it, and as a health professional, I don't have a lot of data on aromatherapy, and it's how, if it's smooth, it helps the person relax and calm down, it may work. Unfortunately, I can't push that. I know that being a vegan is going to work beautifully. I've seen the results. Dean Ornish has done the work. It's epidemiologically supported. I try to emphasize those things that are going to really sort of ratchet down on those risk factors. Chelation therapy is under that same rubric. People go in there to try to chelate the calcium out of their arteries, but then we'll stop at the local Jack in Box or something. It's penny wise and pound foolish. It doesn't make a lot of sense to me. So I try to emphasize those avenues that will help and those that won't try to discourage, not totally say don't do it, but just discourage. Some patients come in, hey, what about this, doc? What about this thing? What about that? I said, well, I don't know much about it. And then I try to find data on it and say, well, it's good for heart disease, good for circulation, good for, this, that, good for I said, well, I'm not sure. There's not a lot of data on it, But I say to people, give it a test of one. If you start taking it 2 weeks later, you can honestly say you feel wonderful, well, then maybe that's good for you. And then you can go with it at that point. Because, they come in and I tell them what I am. They say, you look too good to be vegetarian, or we should be more pasty or something. I says, well, that's the impression that a lot of, then I say, well, have you seen Alicia Silverstone or Alec Baldwin? They're doing pretty good, I'm glad that myth is kind of, being eliminated, but a lot of patients say, I just can't believe you look so good. And, I try to set a little bit of an example and say, yeah, you can do fine without all this, stuff. And they do come back. I do have some patients that really are getting there, and they feel really a lot wonderful. Very rarely I have a patient come back and tell me, oh, I feel worse for, giving up the red meat. It's very unusual. Okay, well, again, thanks again for your time and attention.
Thank you very much, Dr. Kristofich. It is really good to know that heart disease is preventable. It's also reversible. The message is extremely important. And I'd also like to mention Sunday nights, there is Healing in You, Dr. Shintani's old show, and I'm on it as well, Sunday night at 8 o'clock, KWAI, 1080 on the AM dial. There will be some food, and it's out this way for a change instead of that way. And if you're able, if you could put the chairs away, we'd appreciate it. And until then, see you next month. Thank you.
This program is brought to you by the Vegetarian Society of Hawaii, a nonprofit organization dedicated to sharing with the community the many benefits of a vegetarian diet. 3 monthly meetings include vegetarian experts found locally and on the mainland, quick and easy cooking demonstrations, and healthful and delicious food samples. Members enjoy an informative quarterly newsletter, social activities, and discounts at many vegetarian-friendly restaurants and health food stores. For an application, call 944-8344. That's 944-8344. Or visit our website at www.vsh.org. vsh.org.